I think we should request all the audience not to greet each other. All right. Can we get started?
Yes, Bani.
All right. Good afternoon, ladies and gentlemen. Um, First of all, I hope you and your family members are all safe.
Request
We're going through an unprecedented medical emergency of all times. Last 14 months has been overwhelming mentally and physically for all of us. Some of us would have lost friends, family members, or neighbors.
All right, good afternoon, ladies.
We're all wondering what really happened in the last 2 months, in wave two particularly, that escalated the situation, creating such a surge, right, in the number of cases. Just to give you some stats, peak cases went up from 53,000 on March 30th to about 4 lakh on 30th April. Just about a month, it just kind of almost increased 8 times. It was recently reported that the rolling average of deaths has been increasing by 50% each week for the last 4 weeks. I don't mean to be kind of intimidating you, but I'm just throwing you some facts so that we can set some context here. The common perception about the second wave is, is that it's more severe and deadlier than wave one. The younger generation are impacted severely this time around. We've been hearing about some terms called happy hypoxia, and we'll just talk about that, asking the doctors what it is. I think it's just kind of getting really, really serious. As this crisis is impacting lives and livelihood across India, it has become very important for getting the right information on the crisis itself, what kind of precautions to be taken, how do we manage if infected, how can we create more awareness, and how can we support others as well. The purpose of the session is to try and address all these to a maximum extent given the time limit. Before going to the session, I would like to quickly run through HICS intervention in this moment of crisis, just a very, a PowerPoint presentation for your kind reference. Well, ICR in the last couple of months, I'm not going to be specifically talking about wave one, but wave two, the last 2 weeks, we've been very, very proactive in terms of supporting the community hospitals because there's a lot of intervention that is needed there. We were just kind of helping the community centers like Kondapur Public Health Center and also TIMS on the needs for staff augmentation. Maybe it is the nurses, sanitary workers, lab technicians, whatever it may be, right? The medical equipment, supplies, the livelihood support for some of these people who are actually out of the jobs in the IT industry as well. So we've partnered with Nirman and we've done already a lot of impactful work, and the targeted areas are at this point in time GHMC jurisdiction. But now we are expanding it to rural districts as well because there is also a huge need and help that is required in the districts. And so these are the things like the medical equipments and supplies, ICU beds, ventilators, concentrators. So the huge list that is needed. And I think at this point in time, speed of action is very important. And thanks to all the corporates who have kind of come forward to help us. These are the kind of people that they want. Every hospital wants. There's a huge demand, and we've been working with them. And some of the stakeholders that we have been working with, right? TIMS and the TSMIDC, Kondapur Hospital, and the district hospitals, just for a quick review. And see, this is basically the process that we have been following. And we did a need assessment. We started procuring the equipment. We supported the staff in Kondapur Hospital by deploying about 17 to 18 people around the clock. And now we've initiated 2 ICU bed floors, almost totaling about 50 beds. I know everybody talks about where are the ICU beds. So I think we are working on a very such immediate intervention to set up ICU beds. And that's going to be happening very soon. And we are tied up with Nirman, and thanks to the supporting organizations like Qualcomm and Wells Fargo come forward and donating a lot of money. This is what I just talked about, right? We're working with district collectors on the needs at the district level. And now immediately we have done something for the Kamareddy district, 10-bed ICU wards that we have done, and we'll be reaching out to the other districts as well. And the governance of funds, we are very, very particular about how this money is being spent because it is coming from the corporate, and we take a lot of accountability in terms of effectively utilizing these funds. And Nirman is ADG, our partner, and they also FCRS certified. And any contribution from the corporates, they are eligible for the CSR 2% fund as well. So these are some of the partners who have already contributed, the corporates who have already contributed, and now these are the ones which have committed and then in the process of transferring money. We sincerely appreciate all of them who have come forward to help us out in this situation. So going back again, um, again. I'm really pleased to welcome our distinguished speakers for today's session, who have been tirelessly working on saving lives, especially during this crisis time for more than a year. First of all, doctors, my salute to you on behalf of the entire IT industry and the entire, community for your tireless work. It's not that easy at all. We can just say a few words of acknowledgement and thank you from here, but the kind of work that you're doing, the works, environment that you're working in is unbelievable. And again, you are living gods to us without a doubt. So thanks, Dr. Pavan Kumar Reddy, who's a senior consultant, critical care medicine at Care Hospitals, and Dr. Nalini Nagala, senior consultant pulmonologist at Continental Hospitals, for participating in this session. Really appreciate your time. Every minute of your time is so important, and we sincerely appreciate both of them for taking time of their very hectic schedule to share their perspective. In fact, a few minutes ago, we were just discussing with the doctors, and they said, they don't really remember when they spent a lot of time with the family as well. So they've completely sacrificed all their, commitments, personal, social activities, whatnot. So the format of the session will be such that we will hear from them and request them to share the perspective for 10 minutes each. And I will ask them for a few questions and take the audience questions later. And I request you all to just only post your questions in the Q&A window and not the chat window. I repeat, only in the Q&A window and not chat window. We have also collated a few audience questions sent to us already, and I'll be just going to them as well. The intent is to let them clarify many of our doubts today, right, given the time constraints. Welcome, doctors, again. Let me throw this broad question to you both and have you share your insights to start with. What is your thoughts on the impact of COVID, specifically wave 2? Why is this severe? What could have been done to prevent wave 2 and potentially wave 3 that people are speculating sometime in October? I'm just throwing that out. And your experience on COVID patients management briefly from the current role that you're performing as a critical care specialist and a critical care pulmonologist at your respective hospitals. So I request you to limit to about 10 minutes each so that we will move on to the questions at a later point in time. So let me just begin with Dr. Pavan. Dr. Pavan, over to you, please.
Thank you, Barney, sir. If you ask me the questions of what could we have done to prevent this, it's very difficult to say because we anticipated this thing last year. Same sort of a surge, we expected it last year. But then thankfully we shut down the country at a point when we didn't have enough cases going around. But in a country like India, it's very difficult to stop such because we are overcrowded. We accept that we live in overcrowded situations. And population is, you cannot accept. I mean, people think that 130 crores is something, then just a number. But you should know, you should appreciate that, yes, we are a heavily populated country and we live in close proximity to each other. And socially, Indians are more social animals than any other place in the world. You may think that, we live in big families, we're all together, we socialize a lot than anybody else in the other countries. So we are more social beings culturally also. So when you look at our situation, it's very difficult to say that this wave could have been prevented. Now, ultimately for the coronavirus, there is only one way, either to get a herd immunity or everybody gets vaccinated. And that's the bottom line. So in that sense, if you wanted to avoid, it's difficult. If you're going to avoid it this year, it's going to hit you next year. So this is going to happen sometime or the other. So last year when we lifted the lockdown, we had a surge in cases. Our peak was in September, August, September in Hyderabad when we had. That was after the lockdown. So whenever there is a lockdown lifting, then this is going to happen. And this has been mathematically predicted also. If you start the schools, again, the children are going to carry it and then give it to the parents and grandparents at home. So if you look at now, there are no children are getting ill. No, everybody is sitting at home. They're not carrying infections. What usually there's a process of developing immunity for kids is to play with other kids, go out and get infection from one another, and then that's a process of getting immunity for them. But now we are seeing that that is not happening. So yeah, the infections were actually subsided by not opening schools. But then now everybody's got this fatigue has set in. Everybody has got bored of sitting at home. So people started to go around. Everybody wanted the economy to come back because last year there was a, you all know, you're all the software guys, you know how things were hard. Everybody takes an Ola cab or an Uber cab to go home. Now you see, I live in Gachipur. I live in financial sector. I know how the roads are empty now. You go to Microsoft Road, it's empty. For the past 1 year, I was zipping in and out to the hospital in 20 minutes. So we know it's all come to a grinding halt, especially with the software industry, and all those people who live by their daily means have been affected because of this. So everybody was itching to go back to what they wanted to do. In that sense, yeah. So we were all become more complacent. We saw that we were not hit much, so everybody started to become a little complacent. Though we know, as medical fraternity, we all knew that in the back burner that this is going to come. This is going to come back and bite us. But then you cannot hold 130 crore people to ransom and say that this is how you're going to do. It's very tough to control such a huge population. They listened to you for once, they would not listen to you the second time.
Thank you, Dr. Pavan. Really appreciate your insights. So, Dr. Nalini, I think you really set a very good context, and you explained about what all led to the situation. So, you want to just add on to what Dr. Pavan mentioned and share your insights as well.
Yeah, I'll be very brief since he has already in detail explained. So actually, historically also, if you look at other pandemics like Spanish flu and all that, the second and third waves are but inevitable. As he said, till the population either gets herd immunity or gets vaccinated. And whenever there is a change in the people's behavior, like opening up of new things and more unlocking movie theaters, particularly restaurants and all these things, it is but inevitable. But what is unfortunate is that, I mean, it is very difficult to maintain the tempo for a long period. When it's beyond 1 year, everybody gets frustrated, they get bored, and they want to do these things. And that is the reason why all that builds up, and when it crosses certain level, we get a second wave. So, but one important thing that I would like to point out is we know more about this disease now, though there are certain variations in the clinical manifestations. We are in a much better off situation as compared to 1 year back. That is a good thing. So in treatment wise, in understanding the disease and in thinking various options. So I feel this is a very good initiative that has been taken up by HISIA. And if we can give certain practical points to everybody as to what to do in this situation, I think our goal is achieved, and together we can tide over this crisis.
Wonderful. I think that's a very good summary. Thank you, Dr. Nalini. So we've been hearing about all these variants. I think you did mention that as well. So Dr. Pavan, we are talking about so many different variants. We talk about African variant, UK variant, and Brazilian variant. Now there's a Maharashtra variant, again double mutant, whatever. I mean, there are lots of different names that are going around, and now they say that the Maharashtra variant has impacted more than 50 to 60% of the I would say many people who got infected. Of the infected, 50 to 60% are infected by Maha variant. So can you please just throw some light on that as to what are these different variants and why is it impacting and what the severity levels of each of the variants are?
See, the point is any virus mutates for a period of time because virus is nothing but a genetic copy. Like, let me simply explain it in software language. Okay, it's a program code. It's a small code. It's a genetic code. We call it gene, the DNA part. So there's a small code, program code. Now the virus, because it cannot reproduce itself, it uses your own body to produce. That's again the template. It uses your DNA as a template, and then it makes its code and multiplies. So basically, it is using you, is giving a code to you for your DNA to produce some more similar kind of copies, and then it uses them as a nutrition, and then uses them as to multiply. So in that process, there might be sometimes 1 or 2 genes that may escape, or 1 or 2 genes can get exchanged or kind of, missed or skipped, or some sort of structural change happens. And the DNA starts multiplying with the new template that you have given. In that process, there is some variation in the genetic structure of the virion particle. And the virus is a very small, you're talking about DNA, genetic material, which is, you need an electron microscope to see it. So this sort of a small particle, it changes. And for the virus also, it has to survive. In that sense, its basic aim is not to kill you, not to harm you much. It has to multiply by keeping the host alive. That is why you see some viruses which are very dangerous, like Ebola or even the Nipah virus we had in Kerala. So these are not normally for human viruses. They are viruses in bats and other animals. When they accidentally come across to humans, they will kill you because the body doesn't have never seen it, and then the body tries to fight it, and then there's a severe damage. A good virus will not kill you. It causes simple infection like a common cold, multiplies itself, and then goes on to another person. Till the virus kind of goes into such a simple form, it kind of changes. It needs to adapt to your body. So it changes itself a little bit, little by little by little. But especially when it is dealing with thousands of people, millions of people across the world, there is always some sort of a genetic material exchange because it is hitting a Chinese person with a different genetic material versus an Afro-Asian, Anglo-American, so Hispanic. So everybody has got a different genetic structure. So there is some sort of an exchange of material or a change in the material genetically. So it goes into these mutations. Now, for a coronavirus, usually mutations are not common. We see that in flu virus. So we see the flu virus commonly having such mutations. Every year there is a significant amount of change in the structure. That is why when we give vaccines, even for flu, every year you have another different flu vaccine because it depends on the variability that is the different in the strain that is there. So they change a lot rather than corona. But when you are dealing with the pandemic proportions, too many people are involved, too many genetic material is exchanged, too much of genetic material is exchanged. So a little bit amount of genetic change will happen. So that is why you see the mutations. Now we are trying to decipher retrospectively because there is a sudden surge in the infections. We go back and say, why is this happening? So we look at it and say, probably this is the reason. Probably because there's a new structural change, this is able to infect more people. It is causing more damage. So we are going by retrospective logic. We are saying that there are so many cases. Why is it happening? We go in and do it. The importance of this is that you need to understand there are some mutations, and when we make vaccines for these mutations, you need to prepare another vaccine if there is a significant mutation and your vaccine is not working for this. Even if, let's say, you are vaccinated and still it is causing severe disease, then you have to go back to the drawing board and prepare a new vaccine to prevent it from creating havoc. So, such as we see in swine flu, comes in probably that because it changes. The influenza virus keeps changing, and then once in a year, once in 30 years, you suddenly see swine flu come out, and people are not exposed to swine flu before. That's just a mutated variant instead of H3.1 to H1N1. So we call H1N1 is a swine flu. So similarly, every year the structure changes, and then you get a new vaccine for swine flu also, all other flus also, you get a new vaccine. So this is important epidemiologically to also understand, and that mutation basically to see which one is more variant, which variant is more dangerous. So you produce a vaccine which fits for that bill.
So, doctor, then the AP variant or Maharashtra variant that they talk about, right? Recently, today also there was a news about it's really impacting many in Telugu states. So, how far that is true? I mean, is that true that this Maharashtra or AP variant, so-called variants, are impacting the Telugu states?
See, the samples are collected 3 months back. If you look at the prior CCM reported shells in the Indian the government's report, that was collected in September. They said N440K was the highest in Kurnool, and then now they say N440 is reduced to 10%, and the Maharashtra double variant is more predominant. Now, this collection of samples would have happened 3 months back. What is exactly today? We will only get after 3 months. So when you collect a sample now. So we are actually lagging behind on what is, maybe it was 50% then, maybe it is 80% now, we don't know. Or maybe there is a new variant now, we don't know, because you are not doing it in real time. You are collating the data, taking the samples, and then analyzing. We are actually running back by probably 2-3 months.
Understood. Thank you. So, Dr. Nalini, I know that when I even just walk outside, I just kind of, carry that, apprehension or feel nervous about, is this virus airborne, right? We talked about the aerosol, we talked about the droplet infection, whatnot, but at this point in time, even people who want to just go jog, they just kind of are a little bit, apprehensive. And people who are just also inside the house, within the air conditioner room, they also feel that maybe just kind of have that apprehension that it could be airborne within that, constrained environment. So, what are your thoughts on that?
So when this pandemic started, everybody said that it is, particularly the statement from the World Health Organization said that it is a droplet, only what do you call the respiratory droplet infection, and not an airborne infection like measles or something. So what we mean by respiratory droplets is when a person coughs or sneezes, the larger particles that come out, they contain the virus, and they spread this virus to a person who is within 6 feet of distance, and they do not stay longer in the air. In about 15-20 minutes or so, they fall down on the ground. So if we take care, just to stay away with distancing or with a mask, then people said that yes, it is safe. But now there are a lot of research going on. There are so many articles, particularly one MIT article which is published in Lancet, said that in certain specific situations, like in a closed environment, particularly in medical field, we do certain aerosol generating procedures. So what we mean by aerosols here is that the particles that are less than 5 microns in size. More than 5 are called respiratory droplets. These droplet nuclei or aerosols are less than 5 microns, and they tend to be longer in the air for longer time, and they can travel faster. So this 6 feet rule might not apply for these respiratory, aerosols. So is it really true that we cannot afford to go for a jog or cannot take the outside air? No, that's not true. However, sometimes in hospitals, we do certain aerosol generating procedures, like doing a bronchoscopy or intubating a patient, putting on a ventilator or giving a nebulizations. In those situations, if a person is not protected and if he's in the air, definitely it has been shown that the transmissibility is high. So particularly, in fact, in my presentation, I have a slide showing that particularly in a closed setting, like a restaurant where there is an air conditioning, and they're like a function hall or a concert or something like that, these all have been super spreader events. The concept of airborne transmission initially came from the super spreader events, actually started in the West and then it came to India. So these people, why so many people are getting affected, particularly closed environment, and if the virus particles go in the stream of the air conditioning, and if we are there for longer periods without protection, then definitely there is some risk of airborne transmission.
Understood. Understood. So, Dr. Ali, you talked about some presentation. Do you have any other additional insights that you want to share at this point in time so that we can get to the questions later, or is that okay?
Actually, I have a 10-minute presentation. I thought I will go through that. If Pawan has, he can finish his first and then I'll go through mine. I have put some practical important points, just about 10 minutes.
I would just have you go through that because that's very
Okay. Right. Okay.
very important. Yeah, please go ahead.
Yeah.
You can share your screen.
Sure.
Yeah, we've already started receiving a lot of questions, and already we have again tons of other questions that the audience have given even before the session. So I think this kind of overwhelming expectation out of the session. Let's see. All right. Yes, the screen is visible, Dr. Nali. It's all yours, please.
Yeah, thank you. So basically, again, thank you very much for this initiative. I feel this is very much required because on one side, COVID-19 is a dynamic situation. And secondly, that COVID second wave, is more serious and we are trying to control it. Of course, there will be misconceptions. It is but natural. And it is very, very important to have correct information and an action plan. Because unless we have this, I'm seeing certain group of people who are panicking and other group of people who are very casual. Both the approaches are very dangerous in a pandemic. And if we go in the right way, I'm sure all of us can cross this together. And in the last 13 months that we have been treating these patients, hundreds of patients daily, we have been diagnosing, treating, many of them making it, some don't make it. But what I have observed is there are certain gaps. All of us have the knowledge, digital knowledge, social media knowledge, but the applicability of or implementation of knowledge is what is important. And there are certain gaps in that. So my short presentation of 10 minutes is exactly going to be on the simple practical points of what needs to be done and don'ts in this situation. So this is just a photograph. Please go through. This was the Spanish flu in 1918. Our grandparents must be knowing about it. However, at that time, there was no modern medical technology. There were no ventilators, no vaccinations, no WhatsApp or social media. However, they could control it just with two things. One is wearing mask and second is social distancing. Of course, in 2 years' time, millions have died, but we could overcome it. Now we have like awareness, so much of awareness that an information goes within minutes all over the world if you want to send something. But what I understand now is that it is so difficult to change people's attitudes or reaction to a situation. If we need to make a change, is it really that easy? Very, very difficult. I mean, when it comes to our friends, relatives, family members, trying to tell them something to wear mask at all times is easier said than done. So coming to the first wave, we know it has started in China and then it has gone to the Western world. And it was a test to all the countries, the best countries known to have the best healthcare infrastructure. It was actually a type of test and all the countries failed. That means none of us are prepared for this sort of a pandemic situation, a biowarfare or whatever you call it. We are not prepared to this, even now. Then we thought there was a lag, and we in India, with our optimism, we thought the Indian weather is going to be May and we are going to be protected. Indian immunity, Indian hygiene or lack of it, vaccinations, genetics, all these things we thought will protect us. But what happened? The first wave occurred. Yes, definitely we fared better as compared to the Western countries. There were less number of deaths, less number of cases also. And then, of course, there were two important things at that time. One was lockdown, which helped. And the second was there was fear in people. So they didn't know what it was, and everybody was taking precautions in the initial first phase. So that helped to some extent. Then what happened? The unlocking. It's but natural because business has to go on, economy has to survive. So unfortunately, people started taking it easy, no masking. If you see only in the Gachibowli area in Hyderabad, you see masks. If you go to the Medipatnam and beyond that, all other areas, it is as if the pandemic doesn't exist. No distancing, and of course mutations adding. We are dealing now with the second wave. So is the second wave different from the first wave? Yes, we have noticed some differences. It is more transmissible. This has been proven beyond doubt. There definitely has been an age shift. Initially, the people, we used to say the high risk groups, like certain age group after 50 years or above 65 years with some health problems, which we call comorbidities. But now we are seeing people dying in 40s, 30s, even 20, 25-year-old coming with very severe disease requiring ventilation, requiring ECMO. So definitely there is an age shift. And we are seeing severe diseases, involvements other than lungs like heart, kidney, and all those things, brain, early inflammation. So the keyword here is inflammation, and inflammation is occurring early. And there is a lot of surge that is causing, crumbling of the healthcare system. It is going on, but many people are still looking for beds, oxygen, and that is the reason why we are all discussing today. Another important thing, we are seeing disease even without problems, people who are not having any health problems. We call them comorbidities like hypertension, diabetes, and all these things. Obesity is a very, very important risk factor. Now, you asked about mutations. Mutations actually for the virus are like the survival techniques. Sometimes mutations of benefit happen to us, like the virus gets weaker when a mutation occurs. But here in COVID, what happened is some of the mutations are called variants of concern. That means they are significant enough to cause either the infection to be more transmissible, maybe more virulent. And there is another mechanism called immune escape. That means previously if we had COVID infection, now the present COVID virus might not recognize this immunity in our body, and we might still be prone for this thing. That's called immune escape mechanism that has been detected in certain mutants. And of course, we have more treatment options now as compared to last year. Now, in the COVID infection, I wanted to just say one thing. There are different stages. Knowing about the stages and when to act at what stage is very important. In the stage 1, it is a viral phase. That means the virus causes minor symptoms. People might just have body aches or some sore throat, cough, loose motions, weakness, that sort of a thing. So usually people, when they were not aware, they were neglecting all these symptoms. Sometimes there will be a gap of few days, and then second, the lungs get involved. From the upper airway, the virus goes to the lower respiratory tract, predominantly the lungs. So at that time, then that is the time where we have to keep looking for inflammation. What we mean by inflammation is that our body, in trying to fight against this virus, hosts an immune response. And this immune response will be much more than what is required. That is called inflammation. And this inflammation can go in a storm-like way, like how we say a cyclone. Hyperinflammation, that is called, wherein there will be a severe storm. And unless the storm stops, what sort of a damage it can do a cyclonic storm, and also a post-storm damage also. You can imagine how it can wreak havoc in our body. So the most important thing here to recognize is the stage 2, wherein after the pulmonary phase, that means lung involvement is there, but oxygen levels are good. That is when we have to keep a very close watch for certain warning signs, which I will tell you later, because then we need to detect the patients right when they are going into inflammation, so that we can suppress that with steroids, so that the patients don't go into ICU situations. Now, certain drugs have been we have been crazily fighting for these drugs. We are reading in the papers, the remdesivir. It is not a magic drug. It is only, reduces to reduce the symptoms in the acute viral phase. Beyond 1 week or 10 days, the remdesivir does not work. So we have to remember that, and don't unnecessarily go into panic if remdesivir is not available. Please don't try to take remdesivir medicine on outpatient basis or anything like that. It is only strictly in hospitalized patients in a specific group. Plasma definitely has a role. One thing I would like to say, it is not the mainstream treatment for COVID infection. However, in patients who have moderate disease or a severe disease in the early phases, donors with very high titers, plasma only is useful. Just giving any plasma is not of any use. Even if you don't get plasma, don't worry. Now, the third important drug is tocilizumab. Tocilizumab is an immunosuppressive drug, and definitely it has saved many lives. We have seen in last wave and this wave also. But again, it should not be used in all the patients. In people who are responding well to steroids, no need to use tocilizumab. If they're not responding to steroids, we give that only in the early phase. Otherwise, there is a very severe infection risk. So nowadays, tocilizumab is not available freely because of under manufacturing, and there is so much of black market, this thing going on, unfortunately. So now certain areas of concern. We have very high transmission, we know that. And this, whenever the virus is transmitting very fast, mutations tend to occur. So the more we allow this transmission, the more number of mutations. So we need to arrest this. How do we do that? First important step, yes, is vaccination. Even now, certain people are hesitating to take the vaccine. Which vaccine to take? Is it safe or not? No, we should not go into all those things. Any vaccine that is available, we should take, because vaccination is not to prevent the infection, but is to prevent the death. And masking is very, very important. One observation I have made is we wear our masks and go outside. But when we come to our friends, family, and relatives, we remove our masks, particularly when we are gathering. And then it easily spreads in that sort of a scenario. Distancing in India, concept of distancing is very, very difficult. But if unnecessary, do not go out. Only for work, yes, it's important. But for going out for movie theaters and other things, and eating out and all is not right at this time. So another important reason why it is spreading fast is the initial presentation nowadays is very mild, just body aches. We have seen many patients just coming with body aches or just a mild sore throat. They say, I just had ice cream, that is the reason why I had this. But even that could be an initial event, then after a gap of some days, then there will be a severe presentation. So when in doubt, the first important thing to do is isolating yourself, not trying to run for tests and say it and trying to prove whether this is COVID or not. Please isolate yourself, protect your loved ones, and then get tested at least after 2 days. Doing a test very early will give you a false negative test. There are different types of tests. One is an RT-PCR. We all know that, the throat swab. Second is an antigen test. Third, antibody test. So the RT-PCR test is the gold standard. However, it takes time. So COVID antigen test acts like a screening test, the rapid antigen test. If that is positive, then there is no need to go for COVID RT-PCR test, so that we can save time. Only if antigen test is negative, we need to go for RT-PCR test. Antibody test is not for you for diagnosis of COVID. I'm not going into that. Sometimes the test might come negative. Then what to do? There is something called false negatives. That means there is a COVID infection, but the test comes negative. Why? What are the reasons? One is because of the technique. When there is so much of surge and deficiency of technicians, machines and all these things, wrong technique. The sensitivity of the test also is around 60 to 70%. That means even if we have infection in about 40% of people, the test can still come negative. And doing the test, wrong test at the wrong time, that means RT-PCR, if you do too early, then you might miss and it might come negative. And sometimes mutations, because of the mutations also, it might come negative, but that percentage is very small. So the most important point here is that if the symptoms are present and test is negative, do not neglect, isolate yourself and consult your doctor and take the correct advice. Do we need to repeat test after treatment? This is the most thing that we all have to avoid, because we have to contribute. We should not waste the testing kits for this. After 2 or 3 weeks, maximum 3 weeks, and even in severe disease, the infectivity to the other person is not there. So we should not waste our time doing a repeat test, seeing whether we have turned negative or not. So other thing that we have observed is coming to the hospitals with very low oxygen levels. Even now in Hyderabad city, it is happening, even in educated people. So what we need to look for is, if there is, usually in viral phase, there will be a fever. The fever will be there for 5 to 6 days. If the fever is there beyond 1 week, or fever is coming after a gap, if there is an increasing cough, breathing difficulty is a last thing, late thing, or if the particularly detecting the inflammation early, what we need to do is we need to do a 3 or 4 minute walk test daily, morning and evening. And in that, if oxygen level comes down, these are the earliest signs of inflammation. If there is something like that, you have to consult the doctor immediately. Otherwise, rest all can stay home in isolation and there is no requirement for hospitalization. Again, home care, there are a lot of medicines and prescriptions that are going on because of changing protocols as evidence keeps pouring in. So all this hydroxychloroquine, azithromycin, doxycycline are of no use now. There are a lot of failed cocktail of medicines, and in the antiviral phase, in mild, we don't require anything, just isolation, fluids. As I said, monitoring for warning signs. If you want to be happy, you can take your vitamins, but there is no evidence that this is going to help. And certain markers can be done in high risk population, and teleconsult option is always there. It's a big boon now for everybody that can be used. Please do not consider OP remdesivir. And isolation for how long is a very common question. Maybe we can take it up in Q&A session, that thing. So vaccination, different type of vaccines. What I want to say about vaccine is that many of us keep asking, we got vaccinated, but still people are getting infected. So it is not to prevent infection. The goal is to prevent death and severe disease. And please do not try to pick and choose the vaccines. All vaccines that have been released have been reported to have high efficacy in preventing death. So whichever is available, please take it. And one important thing is, in our ICU, in the second wave, what we are seeing, most of the patients, in fact, less than 1% we have who just had a vaccination and came, but majority of the patients who got admitted in the ICU are unvaccinated population. So that itself should be a big boost for our vaccination. I think this we can take in the Q&A session. This I have already addressed about the aerosols and droplets. This is what I talked about in a Chinese restaurant, the initial thing. You can see 3 tables here, A, B, and C. So the people who were, you can see the AC stream coming from there. The people who were along that stream were the ones who got infected. You can see in the other row of tables, the sitting for prolonged time, particularly in air-conditioned environment, is a risk factor. So basically, the new variants don't require new precautions. It is the same precautions which we are well known from the past 1 year. Same thing, masking always, avoiding eating in crowded places, closed places, physical distancing, and washing hands. At the end of the day, we are all there to guide you, to help you out, and we are not giving up. And I'm sure we all can tide over this crisis.
Excellent message, Dr. Nalini garu. I think the essence here is that vaccination is, to prevent death. Vaccination is not to prevent infection. I think that's something, a very, very strong message that everybody needs to understand. And thank you very much for the wonderful presentation, Dr. Nalini.
Thank you.
Now, Pawan garu, I know, just taking some points from her presentation, there are lots of different tests that are available. So today, I've just witnessed some situations where my friends have just gone, had a little bit of symptoms. They went and got the antigen test done, and after that, RT-PCR test done. Everything was negative, but still they had a little bit of doubt, and because maybe they had close proximity with somebody who was infected in their neighborhood or the friends or whatever that stuff is, right? But after checking with the doctor recommended for the chest, CT scan, and there it got, detected. So we were just thinking the first wave that RT-PCR is the kind of a key and the optimal test. But now things have just happened, that we can't rely on that as well now. It's just only the ultimately CT scan. So how do you see the shift? I mean, what kind of precautions we should be taking, and at what stage we should just definitely go for CT scan?
Yeah, you can blame some of us for that, me and Dr. Nalli for that CT scan being utilized so much. Because last year we relied a lot on this because the RT-PCR was not to come fast. We used to send last March, remember that at that point of time. We used to send samples to the government lab and they used to take at least a week for them to come back. To prevent segregation, to do segregation of these patients who are high risk or high suspected to be COVID positive, and because the RT-PCR was not easily available, we started resorting to CT scan based on reports from the West. That even with the mild symptoms, we used to see this ground glassing of face, these typical shadows on CTs. So I think her hospital and my hospital were the only private setups were taking cases at that point of time, and we were resorting to these, unfortunately, at that point of time. But then as time progressed, people started to understand that this is a definite screening tool to quickly pick up patients who might be having COVID. So, but unfortunately, circumstances led to that being now more widespread. Because RT-PCR, now your rapid antigen test is only 50% efficacious in picking up somebody, especially in the early stages of disease. You won't see even CT shadows. The CT shadows will only be seen on day 3, day and beyond. So RT-PCR, like what Madam said in her presentation, the first 2 days, please sit at home, isolate yourself, don't go for any testing, because the first 2 days you may not have enough viral quantity load to even detect on a PCR test. So third day on, you will have enough virus multiplying in your body, in your nostrils or nasopharynx, so that you give a test, you may turn out positive. So rapid antigen is something you are doing it a rapid way. It is not that specific to pick it up. So after that, it's not sensitive enough. So if RT-PCR, you do again have cycle threshold. They say multiple levels of cycle threshold. So each lab has a cutoff, but ICMR says you have to do up to 35 cycle thresholds. So that to detect. So because of faster turnaround, somebody wants a faster report. They're doing multiple numbers, a huge number of tests to be done nowadays. If you want to fly, you want to give a sample. You have to go to Chennai, you have to give a sample. So everybody is taking tests now. So the burden on the labs is huge amount of load. Somebody are doing 2,000 tests a day. Some people are doing 3,000 tests a day. So they cut down the cycle threshold and unfortunately they give a lower threshold. So if somebody has a mild load of viruses, they're not being picked up on these tests. So you get a negative test and then they feel that they're negative and go around. But unfortunately, the standardization of the cycle threshold, such as what ICMR has recommended, up to 35, should be followed by all labs. That is not happening. And sometimes the swab is taken by somebody who is not an expert, let's say not trained enough to do it properly. You have to put it the swab. It is painful actually. If you take one swab, you know. It's painful to get a RT-PCR done. You deep into the nostril, it is put and then rotated for some time and then taken a swab. So a properly taken swab will yield correct result. So when these things, sometimes the tests are negative. That is why people are saying that new mutations probably are not being picked by RT-PCR. Especially, there are some mutations on the spike test, on the spike protein, which are not being detected even in Hyderabad. So even the companies which make these kits are also trying to change their kits testing. So they're making it more different now because as the mutations happen, that is what importantly epidemiologically, when there is a mutation, when there are different sorts of mutations, there's a significant amount of mutations, the genes that you are picking for may not, the epitopes may not be there on that virus. So if you're using an old version test on a new version of, there's not compatibility. So new mutation may need a new kit to be detected. So you're using an old software, you need to upgrade your software. So in the same way, you need to also upgrade the kit to pick up what is actually existent in the society. So I think that is where sometimes you miss out on some of them. But majorly, yeah, you do pick up on the RT-PCR if you're doing it on day 3 and beyond. So day 1, day 2, sometimes you mix up. But
so don't
now
recommend the patients going to just CT scan all by themselves, unless otherwise it is advised by the doctors, right?
see, unfortunately, we all there is a big university called WhatsApp University. Everybody trusted more than the local doctor, local physician. So yeah, so they go for a CT test, and then see the first 3 days if you see it, it will be mild CT on the CT. So you will be complacent thinking that my CT shows mild score, because as the virus multiplies, somebody can get severe. So the exact CT differentiation only will let you know in the second week. People don't really become very ill and hospitalized in the first week. It happens in the second week. So complacency sets in once you do on day 3, day 4, and you do a CT yourself and see that it's a mild return. Okay, you say it's mild. Or somebody are paranoid. They see something in the CT, they become paranoid. So we tell them, don't get CTs. CT will show you something. You get 99% of them walking on the road, you catch them and do a CT for with COVID, they will have some. So 99% of the patients will have some features on the CT on day 3, day 4. So it doesn't mean that they will go become sick. It doesn't mean that they're going to get hospitalized. So this is the important parcel. So sometimes doctors like us, yeah, you can blame us actually to initiate this as a process to pick up the virus, to segregate them, to save the other sicker population that are there in the hospital, to not to club these patients with them so that they should not get COVID. This was initially started because we did not have the PCR coming in at that point of time. So using that now as a screening tool should not be done.
Thank you, doctor. And again, you being in the critical care, so there's a lot of dilemma among the people that, okay, you know what, I definitely need some, oxygen support right now. I mean, they just are already in home isolation or maybe some isolation centers. Are there signs those quarantined at home should keep in mind? We've been hearing news about constantly about the oxygen saturations dropping steeply in few hours, leading to patient needing ventilator support or something like that. I've heard some cases myself that the drop is so significant from almost, like say from 90 to 70 in just few minutes, or maybe when they just remove the oxygen, whatnot. So needing immediate critical care and ICU admission. So what is the reason? What is considered to be a dangerous situation? When do they think that they definitely need an oxygen support?
See what Dr. Nalli presented in her talk. One small thing, that is a 3-minute or a 6-minute walk test we say. Usually there is something called happy hypoxia that we are talking about. Any patient who has a lack of oxygen or a drop in oxygen for some reason, usually there are chemoreceptors in your circulation in the neck. So they detect the drop in your oxygen levels, and then the body starts to take more air in. So you start to become breathless whenever there is oxygen is dropping. But unfortunately, in COVID, what we have seen is these patients do not feel the breathlessness until it is very severe. So initially, even if the oxygen drops to less than 90 saturation, they do not feel breathless. They will be doing their work. They'll be walking about. They would not even know unless you put a pulse oximeter on them. So they're otherwise happy. They're not breathless until the saturation is very low. So that is why even the word happy hypoxia came. But trust me, there's nothing happy in this. So the point is that people have to understand that the only way you can pick up what we call as the fifth vital sign, we say temperature, heart rate, blood pressure, right? Respiratory rate, and the fifth vital sign is saturation, the SpO2 we say. So measuring the pulse oximeter saturation is very vital in these patients. So it is very important if somebody has tested positive or has symptoms which are strongly suspected to be COVID, there is a drop after the 8th day. Okay, these people will not have hypoxia up to day 8. The first week, they will not have this lack of oxygen or the drop. Usually after the 7th day, that is from 8th day to 12th day, is when the symptoms suddenly start to worsen. So during that period, 8 to 12 days is very significant, very important. So these patients, let's say from 5th day onwards, they can put a pulse oximeter, walk for 6 minutes, okay, and then examine their saturation. If the saturation drops after an effortful activity, such as a 6-minute walk or a climb the stairs, or you're doing a 3, even if you can't do a 6-minute walk because of fatigue, because I understand, I asked somebody, calls me up and says, I have so much fatigue. I asked them, can you do a 6-minute walk test to see how your oxygen is? They say, I'm too fatigued out to even walk a few steps. So in case, if you can walk even for the 3 minutes and check your saturation, if your oxygen levels on your pulse oximeter falls less than 94, that means there is a significant amount of lung has already been involved. So that is the reason that it tells you a day or two ahead in time that yes, your oxygen is going to drop in another further 2 days down. So you may approach the hospital or get hospitalized or seek medical attention at that point of time.
Right. So, Dr. Nalli, there's all some videos in circulation that they talk about prone positioning, which means people who need oxygen, right, the saturation levels have gone down. this video showing that people, patients on their stomachs, right? It's called the prone positioning. That really increases the amount of oxygen getting to the lungs. So is that a myth or is it a good practice?
This is in fact a very old practice. I'm sure all the critical care specialists on ventilator patients, they routinely do it for people who have very severe hypoxia, that is low oxygen levels. So instead of going on very high ventilatory support, which are very dangerous to the lungs, we try to do this to improve the matching between the ventilation, that is the air entry, and the blood circulation. So this is called a VQ matching, ventilation perfusion matching. So because the blood supply is more to the lower lobes and there is a large amount of lung tissue in the lower parts, when we prone, that means like babies, we make the patients lie on their tummies, how we make the baby sleep. And then there is a very good matching between this blood circulation and ventilation, and we can optimize and derive the maximum benefit out of this ventilatory strategy so that the oxygenation in the blood improves. So this is a very well established strategy that is used for all the severe pneumonia patients in a condition called ARDS. So that is being applied in COVID patients, in ICUs and out of ICUs also. That means in non-ventilated patients also. And we have found significant improvements. So in ventilated patients, when they're knocked off, lying down on prone, is a well-established strategy. We are applying it now in patients who are on NIV, non-mask ventilation, in oxygen also, particularly when their breathing rates are high. Significantly, initially there will be a lot of resistance. They don't take it seriously for the first couple of days. Then we have to grill it into their mind. We should make them lie down prone and show them what significant benefit. And in 2 days they recognize the difference and say, yes, this is suiting us. So yes, this is a very good strategy for both ventilated and non-ventilated patients when required in COVID.
Just another related question, Dr. Nalini. Steaming is something that many people practice right now. At the same time, some people even have an apprehension if excess steaming is going to affect the lungs.
Right. So basically, one thing I would like to say here is that in the steam, we generate large particles. Okay, these large particles stay only in the throat. They do not go into the lower respiratory tract. That is the reason why when we use an inhaler also, the particles are designed in such a way that they go to the lower airways. So the steam stays, one thing we have to remember is that it stays in the upper airway only. It doesn't reach the lungs. So the idea of steaming, the concept of steaming came to clear the upper airways, or maybe with higher temperatures, whether it will have an impact on COVID virus. People have done some studies also, particularly in Italy. There was a recent study wherein, for people who got infected with COVID, they steamed for about 4 cycles each for 4 or 5 minutes or so. And they found that some people have turned COVID negative, particularly when it is present only in the upper respiratory tract. However, the guidelines, particularly from CDC or WHO, do not, say anything that steaming is beneficial in COVID infection. There's no harm in trying, but we have seen, and also it has been well documented, that with steaming, burn injuries are very common. We have seen children coming to our hospital with scalds and other burns because everybody in the family is steaming themselves. So this sort of accidents are very, very common and dangerous.
Okay. So, Dr. Pavan, I think this is a very, very commonly used question nowadays, because now that the first vaccination was done and the second shot was just kind of delayed because of the short supply and all that. I think they missed the window of time between 4 to 6 weeks for Covaxin or 6 to 8 weeks for Covishield. So if there's going to be delay, will that really have, will have nullifying effect on the first shot? So what is your view on that?
See, the response to any vaccine depends again on the body's response to produce antibodies against the antigen that we present in the vaccine. So when it was done in the UK, what they thought is at least one dose of vaccine will cover a lot of population, because they had a lot of elderly population. They had a wide amount of population to cover for vaccination, to get to maximum reach of vaccination to maximum number of people. So the government in the UK decided to give it to all, at least first dose. Second dose we will get whenever we have a supply, we will do that. So they established between 12 weeks. They said first we will give now, and the second dose, instead of the 4 weeks, we will go for 8 weeks or 12 weeks. Let's see what, at least we'll cover maximum number. But when they really studied it later on, they realized that the antibodies response after giving it around 12 weeks, with a gap of 12 weeks, was actually better. More amount of antibodies were produced in those population in UK. vis-a-vis compared with those patients who were taking it for 4 weeks, with a gap of 4 weeks. So in that sense, again, they started to generalize that, and then people started to realize that though the company tried, when the vaccine scientists actually tried to look at, they usually look at 4 weeks because they believe 4 weeks is an optimal time. But when you look at, because see, when you do a study, any studies, normally when the vaccination is rolled out, it's such a short time. You do it in probably 10,000 people. But when you're doing it over 1 million people, you get more number of data, more report, more results. So when they looked at the UK population, they realized that yes, those who received 12 weeks later actually had a better antibody response. So that's the same reason, again, the government started, even in India, they said 6 to 8 weeks for Covishield because that was studied. The Covaxin was not given elsewhere. So Covishield is something that was given in the UK, the AstraZeneca Oxford vaccine. So they have the data saying that 12 weeks is better than 4 weeks for antibody response. So Indian government also followed suit, especially when the Indian government realized that we also were running short of the vaccine Covishield. So Indian government also prescribed the same thing and said, so now because there'll be conflict because the doctors took it for 4 weeks, all the frontline healthcare took it for 4 weeks between, and then you are telling the subsequent because the vaccines were short again on supply, so the government had to change and say, yeah, up to 8 weeks is fine, up to 6 weeks is fine. So in all, I say at least one dose of vaccine is better than nothing, and 2 doses of vaccine at whatever time, 12 weeks, 6 weeks, 8 weeks is better than single dose.
Okay,
so
great. Thank you.
Two doses is better than one dose, irrespective of the time gap, and one dose is better than none.
So I would just tell the audience here just not to get too worried about, you've not got your second vaccine in 4 to 6 weeks.
And then let me tell you, let me also remind that this vaccine, we are not going to work more than a year time.
Yeah.
So these vaccines will not give you offer immunity or whatever antibodies in all, majority of them. There may be few who keep getting re-exposed to virus again and again because somebody in the family has got it. So they may continue to have antibodies, but majority of them will not have antibodies beyond a certain period of time, which we think at this point is probably 8 months, 6 to 8 months or 9 months maximum. So you may have to take one more booster again, 9 to 10 months there, depending on the variant that is more predominant at that point in time.
Okay.
So
All right.
this may be an annual event for majority.
Yeah, thank you. Thank you. And doctor, just another leading question. I think a lady is asking this, new mother. She's saying, is breastfeeding women can take any vaccine? Is it safe?
Yes, breastfeeding, you can take vaccine. Vaccine is not an issue. The only those who are contraindicated for vaccine are anybody who had an allergy to the same vaccine. Let's say first dose you have taken and you had a severe reaction, your BP dropped, you crashed, almost it became a life and death event. Only those are the patients who should not get a second vaccine. Apart from that, anybody else can take a vaccine. So if you had a severe reaction to the first dose, right, life-threatening, you went on a ventilator kind of situation, then you are the only person who is not supposed to take it. But apart from that, everybody, even cancer patients, take the vaccine. They may not produce antibodies because they're on therapy, chemotherapy, and other drugs. So their body is not producing enough antibodies even if you take vaccine. But then there is no harm in taking the vaccine. It may not benefit them as much as a regular person because you are taking on a lot of these medications, powerful chemotherapeutic agents. But even for cancer patients, we give it. Even for penicillin allergy, you can take it. Even for blood thinners, patients on blood thinners, you can take it. You can take. Everybody can, except for somebody who has had a reaction to the first dose.
People are asking about some diet restrictions as well. So once you get vaccinated, should we just stay on some specific diet or non-veg is okay?
See, the major questions people came and asked me, I'll tell you, very important. Somebody, especially in Telangana, people ask is, can I drink? It's not about food. Food is just a surrogate question here. People ask, can I drink? See, the idea is that, yes, you can take, if you're a social drinker, if you take 1 peg a day, it's fine. 1 ounce a day, it's fine. The idea is not to binge because alcohol will also drop your immunity. So if you take a significant amount of alcohol, then you may not produce enough antibodies or the vaccine may not be of much effect in the sense you are not producing antibodies. So yes, Telangana, it is a very significant question that comes across. Food-wise, I don't think there is any sort of a restriction. You can eat whatever that you are routinely eating. There is nothing like that. You can't take food.
Absolutely. All right. So I know there's some questions about, is Covaxin better or Covishield better? I think there's enough been talked about it. And I think what is needed is only a vaccination. So I think Dr. Nalligaru very nicely put it across. So let's not just get confused with all that stuff. So And I'm just going to a couple of more questions. I know that we are just about 5 o'clock, and maybe we will take a couple of more questions and wrap it up in about 10 minutes. Doctors, if you're okay, because I know your times are very,
Yeah.
very essential, and you're in life-saving situations. Yeah. It says after symptoms of fever, throat pain, loss of smell test, which day we need to take RT-PCR test to confirm if it is COVID or not. Nalli Garu?
Shall I take it? Yeah.
Yes.
So basically, as I said, once the symptom starts, we try to wait for third day. Because doing too early, the virus load might be very low in the upper respiratory tract and we might miss detection of the virus. So whatever symptoms are there, the first thing to do is isolation so that we don't spread to our family members or work at the workplace, and get tested on day 3.
Okay, thank you. And again, leading question, Dr. Nallingaru. A person says that I have a 4-month-old baby, not sure what kind of impact this COVID has on babies. Can you please share any precautions that needed, especially for babies?
So as such, there is nothing. Fortunately, children, the first wave have not been affected much, and we are not seeing severe disease at all in children. Very few children in the second wave, and none of them are in the ICU or requiring critical interventions. But particularly children below babies, that is less than 1 year, are not having any problem as such. So nothing to worry about. But if the mother is positive, then all precautions like masking and hand washing before handling the baby is very important. In fact, breastfeeding also can be encouraged provided all precautions are taken to prevent the transmission to the baby.
So another gentleman is asking, I'm equally scared with COVID and vaccine. I have history of reaction, high fever arising from vaccination, which led to neurological disorder that I'm still scared about. What should be the action from my perspective?
So serious adverse events have to be reported, and it has to be labeled as serious adverse events, because a high fever is not a serious adverse. It is an expected reaction to a vaccine. That means vaccine is starting to work. So in the first 1 to 3 days, people can develop fever, body aches, and all these things, in fact, and it is expected. So that doesn't come under serious adverse event. If it is a neurological event, sometimes certain demyelinating diseases can come after vaccination, and those are very, very, very rare. If truly that sort of an event occurs, then it has to be reported, evaluated, and then the second vaccination at that time we need to look into, and it might not be warranted.
Yeah, so there's another gentleman, I think I heard this questions multiple times. He says, if we have symptoms of COVID but afraid to go for a test, following precautions in home isolation, what could be the time period, 1 week or so, of need to go for a hospital? I think, first of all, you know what, I think one thing I also said, I don't think it requires doctor's advice, but I'll tell you, COVID absolutely is just more of a viral disease. And I don't think one has to have stigma about, okay, oh, I got COVID and I just don't want to be doing the test and not informing others. You know what? There's absolutely nothing to worry about. And I'm sorry, I'm just speaking for you doctors, but please go ahead and get the test done.
The idea of our webinar today is the same thing: to allay your fears and anxiety, give the correct information so that you can act timely to each situation.
Absolutely, absolutely. So it says, based on the current intake of cases, what is the time you think, based on treatment, vaccination progress, herd immunity, when can we expect reasonable amount of normalcy? Pawan Garu?
Difficult to say, because the cases are increasing. They will increase. It will hit somebody known to you. You will see somebody known to you, or heard that somebody had a severe COVID, somebody had been admitted to the hospital. So you will keep hearing those. It will go on for the next probably 2 more years. We will see these waves, and third wave, fourth wave, little till the whole of the population has had it at least once. So yeah, we are all going to get it. There's no escape from it. We haven't got it in the hospital. We have been trying to take ultimate precautions. Majority of us in the hospital have not still got it. We don't know how our body responds to it. So everybody has to go through it. There is nothing like you can escape it forever. If not this year, you will get it next year. So COVID is not something to be ashamed about or be feared about. It is something, unless and until you go through it, you will not get it. The only point is that, yes, if you can get a vaccine done, unfortunately, we know the vaccine situation is that we don't have the stocks enough to give the whole population, at least the adult population, we are not able to give it. So the idea was to at least give it to those who require it most, or got exposed to frontline people and the senior citizens, to actually those who we expect them having high viral contact and probably having more severe infections. But the youngsters, let me assure you, you will hear that there is a small young kid or a teenager or a 25-year-old, 30-year-old who got severe COVID, but it is not the norm. It is out of exception. There are people with different sorts of immune levels of the body. We have seen twins, those who live in the same house, grow in the same house, wear the same clothes, look same, genetic material same, but still one of them will skip out not having any COVID. One of them may get hospitalized. So it all depends on how your body is going to respond to the infection. It has nothing to do with the severity or the type of virus, because it's ultimately your body, how it is responding to the virus, and how we are going to modulate that response. So we have seen whole families get infected with severe COVID. We have seen one or two in the family getting infected, rest of them do well without any problem. So it all depends on your own body. So the the baseline thing is, yes, you're eating right, you're fit. What we can do is keep yourself fit, keep stress levels low, try to keep yourself relaxed. Do not be panicky. Do not be. What we have seen, even in the ICUs, those who require very high oxygen, those who had a positive attitude about life, positive attitude about things, actually they came out even from the severest COVID. Those who are very anxious, they deteriorated very rapidly. So that is also very important. Yes, not to be paranoid about things. Yes, it is something. It is very hard conditions, hard situations at this point of time. Yes, some of our families are going to get affected. Some of us are going to get affected, get severe disease, but that is not a cause for panic. Ultimately, remember that India will still have 130 crore population next year also. The country will go on further. So you all understand that this is something that we will all get through.
Yeah. So Nalligaru, I think a mother is asking a question. I have a question. How can we be safe being at home with kids? My kid keeps everything in his mouth, getting difficult to manage him at this pandemic days, and I'm very scared.
Yes, in fact, I skipped one of my slides in my presentation where it shows the routes of transmission. So basically, the most important route of transmission is through your inhalation only. So the respiratory droplets are going to spread the infection. Now, when it comes, sometimes one day before the infection, before we develop symptoms, we might be still infective. But from the surfaces, what you mean by surfaces, right? The kid goes here and there, touches this, and then whether the infection, the chances of getting that now very clearly, the international guidelines have said that from the surface, the transmission rate has drastically come down, much less than what was considered earlier. So we don't have to be very finicky about trying to clean all the surfaces always, and always on the edge of anxiety. If somebody touches something and then puts in the mouth, something will happen. We don't have to be like that. Only thing is they can touch everything, but try to inculcate one habit in them, that before touching or keeping in the mouth, try to wash hands, particularly in little older children. But in very young children, it is very difficult to make them practice that. Even we tend to forget, and we try to touch our nose and mouth. Only in this last 6 months I have learned strictly not to do it. So I would suggest, don't get over anxious about it. As Dr. Pawan said, anxiety is one thing that will bring our immunity levels down. Trying to always look into, is the child doing the right thing, are my parents doing the right thing, trying not to touch anything, that actually puts a lot of pressure on you. Try to do whatever best possible in the given situation, and accept and hope for the best.
That's a very good message. You keep your immunity levels high by keeping your anxiety levels low. You don't need a vitamin C or zinc tablet or all that nuts and things that you take, but I think you keep your anxiety low in the situation. Stay calm. Things will definitely be better. And another important question many people have asked Dr. Nalini is that, okay, one is tested positive, they're in home isolation, about 10 days, 15 days. Do they really have to go for a retest to confirm it's negative? Or after 15 days, it is deemed negative?
So as per the recent revisions, now they say for milder infections, 10 days isolation is enough. After that, you can start going to work. In fact, people, and in office spaces, offices, people asking for a negative test. This should be discouraged. In fact, you can give a government guideline saying that repeat testing is not required, because after mild infection, after 10 days, the chance of spreading to others is negligible, and that is the reason that guideline was made. If a person has a severe infection and has landed up in the ICU, and if there is a high risk population at home, for them we say 3 weeks. After 3 weeks, the chances of spreading to others is not there. So either way, there is no need to repeat a COVID test after confirming the diagnosis. We know we have the COVID test, and if we repeat sometimes for 2-3 months also, the dead RNA will be there in the throat, and that will be picked up by our RT-PCR test. So we are not trying to gain anything. And I have many patients who got tested after going home and said, "Madam, again I am turned positive, or I have not turned negative," and then that adds to another level of anxiety. So we have to remember that in 10 days it's gone, or maximum in severe cases 3 weeks it is gone. There is no need to repeat a COVID test. One more thing I would like to add here is, when we go out, buy something, vegetables and all things, please don't try to wash everything. Don't wash your vegetables with detergents. That will lead to another set of problems. Just routine cleaning. Don't try to wash everything. Wash your hands. That's all. That is enough. Please don't wash all other edible things.
So I'll take the last question. I know there's tons of questions here, and we try to do justice to the extent possible. The gentleman says, a lady says, I'm vaccinated 5 days back. I'm tested COVID positive yesterday. Is it because of vaccination? Am I eligible to give plasma? So, Dr. Pavan.
So the vaccine, you see that there are two things to the vaccine. There is one is what we have in India is the Covishield and the Covaxin. The Covaxin vaccine is basically an inactivated virus. So it is given intradermally and intramuscularly into your hand. It doesn't go into the bloodstream. The virus is not seen even in severest COVID. It doesn't enter the blood. So what you are giving here doesn't come through the nose. So basic thing is that because you got the vaccine, probably became complacent, went around and then got it. So the vaccine has no way to do anything with this. And Covishield, you don't have the virus at all. You only have a small particle of the virus embedded in another chimpanzee virus. And then that virus is given. The fever for the getting after Covishield is basically from the chimpanzee virus, not from the virus that actually COVID virus. The patients get fever because they get a lot of chimpanzee virus given. So that adenovirus is also given. So that adenovirus, they take a small particle of the COVID virus, the SARS-CoV-2 virus, and put it in the chimpanzee adenovirus and give it. So that's the chimpanzee virus that's causing the fever, not the COVID virus that's causing fever in this patient. But it is very important because everybody expects fever to come in after the vaccine. And then when they go around and they get actually COVID virus, they will get the SARS-CoV-2 infection. They think that it is because of the virus. So any fever more than 2 days beyond the vaccine, you may have to go back and look into why that fever is. Don't neglect it to be because of vaccine virus, because vaccine virus will not be there for 2-3 days beyond it. First 2 days, you may have, like any other cold flu virus, you may have some myalgia, muscle pains, and other things. But third day on, if you're still having fever and symptoms or cough, that means you got infected in the meanwhile from a real person for some person. So that is what happens when you get vaccinated. You become a little complacent, think you got a vaccine, you have won the world. So that is not the way. Even if you have got the vaccine, you still have to mask up. You still have to maintain your social precautions because you can still get infected.
Wonderful, wonderful. So, all right. So I'll just close it here because I don't want to be taking any more questions. Otherwise, we would definitely need a couple of more hours. Kind of very overwhelming. And I'll just request the doctors to just give a very quick 1-minute advice to the audience. So, what is that they have to do to stay safe? Please, 1 minute, Dr. Nalini Garu.
So I would go by the same thing, and VMD, vaccination. Please, every one of you go for vaccination once it is available, particularly 30s, 40s, since they have not been vaccinated. And always wear mask, though it is tiresome. Please do not remove. The most important thing here to do is, we think that it's only my friend, I'm going to be all right, and you eat together, 4-5 people together. We don't know what the other person is carrying. So masking, and try not to eat together if possible. Particularly if unvaccinated person is there, then it is better you don't get exposed expose them and all that. So masking, and then as far as possible, try to avoid entertainment and recreational activities during this period. We can always go for vacations next year. Okay, because it's coming cheap, let us not risk ourselves and add to this pandemic.
So we have to live first to have vacation next year. Dr.
We can for a change enjoy at home.
Dr. Pavan.
I'll tell you one thing. Last lockdown, we did not have any heart attacks. We did not have any strokes. Very stress-related disorders did not come because everybody was sitting at home during the lockdown and they were probably spending more time with their families. So yes, stress is a great problem, great issue. So patients, people, everybody is stressed out because of COVID at one sense, and they're stressed out because of lack of daily social communication that they have, except for the social media. They're not doing the social interaction that they would love to go to pubs, go to bars, go to movies, that they can't do it nowadays. But yes, stress can be relieved from other ways. You can cultivate a good hobby if you're sitting at home and working from home. Yeah, definitely. When your kids are on top and they have the summer holidays, it's very hard for parents to not get stressed. But then we have to deal with stress in different manner. So that is one thing. And don't worry about the virus. Yes, we all have to go through. Everybody will get the virus at some point. If you test it, you may be positive. Don't test it, you can get it for a day or two, and then it will be like any other cold. So everybody will get it. And in India, because India is a humongous population country, you will hear all kinds of things. Patients, some of them will die, some of them will have problems, will listen. That majority of them, especially this is very true this time, because when there is a surge of hundreds and thousands of people running towards the hospitals, you won't get the same amount of quality to all. So that is going to be a problem. Our idea is always the lockdowns and all these restrictions are basically to make sure that everybody gets the infection, not at the same time.
Right.
Everybody will have to get the infection at some point, but you space it out. Not everybody gets it. So there is so much of overwhelming circumstances in the hospital. We don't want that happening. We want people all to be healthy. We don't want thousands. We are running out. We are running out. The psychological pressure that is on healthcare is humongous. It's very tough because patients who get sick, they languish in the hospital for a pretty long time. The beds are occupied because the patients are sick, and then they are there for pretty long time. So on that sense, I think we have to try not to catch the infection when there is a shortage of beds in the hospital. So try not to get the infection now. You will get eventually, but then it should not be when you can get a bed in the hospital, when you're free to at consult, when you are relieved of all that, you get that most care.
Wonderful, wonderful. I think excellent message from both of you. So just take your vaccination. Don't get worried about whether it's going to get delayed, the second shot getting delayed, whatnot. But take the vaccination and take all the precautions, the COVID protocols. Every day you keep listening to them, and don't spread panic. Maintain and let's say calm, and don't get too anxious. That's going to reduce your immunity. A lot of wonderful messages that today both the amazing distinguished doctors have given us. And this particular session, the video recording will be made available on ICIA website. Going to ICIA.in, and there will be a resources tab. Under that, you'll see this particular recording. And do subscribe to ICIA.in, and also in the Facebook and Twitter and LinkedIn as well. So you will get all the updates. And thank you very much. We tried to do justice in terms of covering a lot of questions that you have. And again, this is kind of very overwhelming. We'll also see if required, we'll just have another series, maybe in the next couple of weeks to, as a follow-up session. Thanks again. And please do remain safe. And request to you is that we are trying to support the communities and community hospitals to the extent that is possible. You go into the ICIA, there's a link to even individual donations for all the kind of support that we are offering to the community and districts. So please do donate, and request your friends and your corporates also to donate. So thanks again. God bless you all. Stay safe. Thank you very much, doctors. Really appreciate your time, and wonderful chatting up with you. You stay safe as well.
Thank you.
Yeah, both of you stay safe. Thank you so much. Thank you, Bernie.
Thank you, Neeraja. Thank you.